So we can see your screen.
Okay. Okay, thank you very much. I'm very grateful to the organizers, particularly Dr. Iftikhar and Dr. Harun Yusuf, for inviting me for the 5th virtual international conference of Shalamar Medical and Dental College. It's a pleasure to be given this opportunity to talk on a very important topic. I apologize for changing the title slightly, making it less harsh: common and uncommon mistakes in the management of hepatitis B virus. And thank you, Iftikhar, for a very kind introduction. And I will move on to the presentation straight away. I have no disclosures to make, and I bring greetings from my hometown to all those joining us from outside Lahore. So I'll jump straight to the mistakes that we make in the management of hepatitis B as a whole. So let's talk about mistake number 1. In my opinion, mistake number 1 is not to screen for hepatitis B, particularly living and working in Pakistan. You can argue that general population screening is probably not cost effective or possible because of lack of resources and lack of will. But at least high risk groups should be targeted, and you should have targeted screening and antenatal clinics, blood banks, and other healthcare facilities. Ideally, you should screen by testing for HBsAg, anti-HBs, and anti-HBc to differentiate between non-exposed, non-vaccinated, and if HBs and anti-HBc is positive, then remote past exposure and the patient is immune from natural exposure. If only anti-HBs is positive, the guy has been vaccinated in the past. If only anti-HBc is positive, then it's either past exposure or maybe a false positive anti-HBc. We used to ignore this in the past, but now when we use strong immunosuppressants and chemotherapeutic agents, these should be kept in mind. The patient and the physician should be mindful of the fact that if this patient requires future immuno or chemotherapy, he may require preemptive therapy, as we call it. Sometimes to save cost, we just check Hep B surface antigen and not the other antibodies, which is fine. Negative negative HBsAg with no history of vaccination is an indication for vaccination. Now, in Pakistan, which is an intermediate prevalence area, everybody is at risk. So there is no harm in wherever you are working, any patient, even coming with headache, to screen and vaccinate if is not already been exposed or vaccinated. So coming to mistake number 2, doing the test, identifying that the patient is susceptible, and then not vaccinating. So that's a major blunder. And we see a patient with CKD comes to me for dyspepsia, and I find that HBsAg has been done, and this patient hemodialysis has never been told to get vaccinated. So what a loss. I really sometimes wonder that this is a major blunder that we are doing, not thinking about all these things while we are seeing patients. Coming to mistake number 3, not evaluating patients properly by doing appropriate tests. What are the minimum tests that you need for a treatment of a patient with hepatitis B? CBC, INR, creatinine, sodium, sugar, LFTs, albumin, alpha-fetoprotein in select groups where a patient has cirrhosis, HBsAg, E antigen, anti-HBe, anti-HDV, anti-HCV, HIV, and quantitative HBV DNA. Ultrasound abdomen, in my opinion, should be done in all patients, and it's cheap, readily available, and there is no problem. And I wouldn't think that it will add to the cost. EPRI and FIB4 is poor man's fibroscan, and one should always do that. Very good in early and late. So at least you can identify F3, F4 fibrosis by doing these tests. The other tests may be optional: TSH, fasting lipids, HbA1c, fibroscan, shear wave elastography, and very rarely liver biopsy these days because of the availability of better tests for fibrosis. I would like to highlight here that we are not doing in practice always screen for HDV in all HBsAg positive patients. Whether DNA is positive, whether E antigen negative or positive doesn't make any difference. Anybody who is surface antigen positive should have anti-HDV tested. Next mistake, not counseling your patient. Now you have a patient in front of you, diagnosed hepatitis B, you have all the data in front of you, and then you just write a prescription and send him home. This is not right. You should not even think of writing a prescription until you have done that. Explain the natural history of the disease, what changes in lifestyle. He's a married man. Is his wife related? Is there any risk of him spreading it to his immediate family? What about protection from hepatitis A and E? A is not a problem in adult population, but Hep E is still there. And these people don't do well. B positive, they get E and deteriorate very rapidly. Have we talked to them about vaccination for flu, pneumonia, particularly in those who are decompensated, have multiple comorbids, and now COVID-19 not? Instead of patient asking or going from your clinic unclear whether to vaccinate for COVID-19 or not, you should preemptively guide him and tell him that this is what should be done. What about the diet? You must talk about it. In a healthy patient with normal liver, no dietary restriction, and they should be encouraged to eat a balanced diet. And certainly talk about hepatotoxic drugs and alcohol. And don't forget family vaccination. So you need to tell the patient that, get your family. If they are negative and not vaccinated, they should get vaccinated. So it is important to talk about these things. And this is the mistake that we are making every day, although with passage of time, this is becoming less and less. Next mistake, not sticking to guidelines on selecting patients for treatment. So what do the guidelines tell us? Obviously, active chronic hepatitis B, whether E antigen negative or positive, viral load more than 20,000, ALT more than twice upper limit of normal, just start the treatment, regardless of the degree of fibrosis. Cirrhosis, E antigen positive or E antigen negative, whatever the ALT, if HBV DNA is positive, and I will repeat, if HBV DNA is positive, whatever the level, this patient should be treated. Those patients who are DNA negative, this is questionable. One should make an attempt to find alternate causes of liver disease before making a decision whether you want to treat with negative DNA or not. But the guidelines only tell you that you should treat cirrhotics if DNA is positive, whatever the level. Third indication, E antigen positive or negative, DNA more than 20,000, ALT more than upper limit of normal, maybe less than twice upper limit of normal. This is with moderate inflammation of fibrosis. This patient should be treated. I'll just talk about what is significant inflammation and fibrosis in the next slide. Now, immune tolerant or E antigen positive chronic infection patients in those who are more than 30 years old should be treated even if ALT is normal or there is no fibrosis on fibrosis assessment. So this is a new indication, but as you can see, the degree, the weight of evidence and the degree of recommendations are all very weak. But you may treat, you may follow up. Both is correct. A question is always asked and discussed: why not treat all immune tolerant patients with hepatitis B? Well, the answer is very simple. Ordinary people should stick to guidelines. Those who make the guidelines or who are the experts can pick and choose. So I would advise for every one of you to stick to guidelines, except those few who are experts in this field and they can play around. And we should, if we are among the ordinary people, we should refer such patients to at least once to make a decision to those. If your patient is positive or negative, but with family history of HCC, cirrhosis, or extrahepatic manifestation, does not fulfill the criteria given above for treatment, he can still be treated, although the evidence in favor is weak and the recommendation is also weak. So in these two areas, which are new by EASL, you can choose to treat or follow up. Whatever you do is not wrong, but it is best to stick to the guidelines for most of the physicians who are treating hepatitis B. In the previous slide, EASL recommends E antigen negative or positive more than 2000 ALT, more than upper limit of normal, if they have significant fibrosis or inflammation, they should be treated. What is this? Any fibrosis score of equal to or more than 2 is what we call significant fibrosis, whether checked by EPRI, fibroscan, or liver biopsy. F2 equal to F equal to 2 or more than 2 is an indication to treat. Unfortunately, necroinflammatory activity cannot be checked without liver biopsy so far, but just to tell you that A2 is the degree of inflammation where you need treatment. Some people ask what are the normal ALT values, but this is only relevant in US. ASLD in 2018 has finally changed it to 35 in men and 25 in females. So this is currently the normal value of ALT in the US. Rest of the world continues to follow the same according to the lab normal values, which is generally 40 or 45. Mistake number 6, not using recommended drugs for treating chronic hepatitis B. Fortunately, this has become rare because those drugs which are not recommended are not available. So let's know what is recommended. Entecavir, tenofovir, alafenamide, and tenofovir disoproxil fumarate are the oral drugs or nucleotide and nucleoside analogs which are currently recommended by all the guidelines for use in chronic hepatitis B. PEG interferon still continues to be used, but should be used carefully in compensated cirrhosis, and it is contraindicated in decompensated cirrhosis, as we know for a long time from our interferon era in hepatitis C. All these oral drugs are so far considered safe for up to 8 to 9 years of use, are of high potency with high genetic barrier for resistance. So they can be used safely with good outlook in patients with chronic hepatitis B. Next mistake, not using appropriate dosage of drugs, particularly in CKD. What are the dose of drugs? Entecavir 0.5, TDF 300, and TAF 25. They are okay up to, particularly entecavir and TDF are okay to creatinine clearance of 50. But less than 50, need to adjust the dose. So simple formula. How do you do that? 30 to 49, one tablet of either entecavir or TDF every other day. 10 to 29, one tablet of entecavir or TDF every third day. End-stage renal disease, creatinine clearance less than 10, and on hemodialysis, 300 milligram every week. So simple, you can easily remember that, but I'm really surprised that still today, we see patients with CKD 4, 5 on normal dose of entecavir or tenofovir. There is no dose change recommended until the creatinine clearance is less than 15 mil per minute. So that is why it is a good option, which is now available for patients with CKD. And you can use them until creatinine clearance of more than 15 without any dose change. When should you select entecavir or TAF over TDF? If your patient is more than 60, has any bone disease or renal disease, you should either use entecavir or TAF rather than TDF. And it's good that we have these two options, because TAF should be prioritized over entecavir if a person has previous nucleoside exposure, particularly to lamivudine with or without adafovir resistance. So you should use TAF. So both drugs are useful. TAF is better over entecavir in certain situations, including HIV, HPV co-infection, and particularly if there is CKD and creatinine clearance is more than 15, but less than 50, you can certainly use TAF with any dose adjustment. When to prioritize entecavir over TAF, if less expensive, like in Punjab hepatitis control program, if entecavir is available and TAF is not available, use it. You can alter the dose in CKD, but use it. It is free. It is available. So it depends on the availability as well and the cost. So keep this in mind. You must remember that TAF, tenofovir alafenamide, is not yet recommended in decompensated cirrhosis, pregnancy, and in children. What do you do in patients whom you have been treating for up to 2 years maybe, and the viral load is not negative, less than 2000? The answer in the guidelines is continue treatment. So don't change, don't stop or switch. Just use the same drug and what we would like to do. Next mistake, not stopping therapy on reaching appropriate endpoints. What are these endpoints? Optimal endpoints need to be defined. In E antigen positive patient, it is E antigen loss with seroconversion, along with HBV DNA suppression. To what level? Certainly less than 2000, but preferably negative. Finally, Hep B surface antigen loss and seroconversion is the ideal goal, but rarely achieved with oral drugs that we have today. So for many endpoints, indefinite therapy may be required, and particularly in those patients with advanced fibrosis that is F3 or cirrhosis that is F4, lifelong or prolonged therapy is what we can do so far until the newer drugs come in, where the guidelines may guide us how to change the practice. Thus, patient selection and education are critical. What to do in E antigen positive patients? Those who seroconvert to anti-HBe on NA therapy. If there is no cirrhosis, consider discontinuation after what we call a consolidation phase of at least 12 months. But we all know that the longer, the better. And I'll show you some evidence for that. Alternative approach is to treat until surface antigen loss, which is achieved in E antigen positive patients, but to a very minimal degree. Across the guidelines, length of consolidation therapy varies. APASL and EASL 12 months minimum. APASL preferably 3 years. So, as I said earlier, the longer the consolidation phase, the better. What does consolidation phase means? E antigen becomes negative, anti-HBe appears, and then you continue your treatment for 1 to 3 years and then stop. This 1 to 3 year period is what we call the consolidation phase. What do we get in E antigen positive patients? E antigen seroconversion in 1/3 with interferon and around 20% across the board in 1 to 3 years' time. Surface antigen loss, about 8% in PEG interferon in 1 year, although it continues to rise even after stopping therapy and maybe up to 18% at the end of 5 years follow-up. Whereas in oral drugs, it is less, maximum with TDF of 8% in 3 years' time. And it goes up to about 14 to 15% after 8 years of treatment. So it does happen in E antigen positive patients, but is very rare and less common than interferon. Why did I mention about the consolidation period? Why did I emphasize it so much? This is the evidence that if you keep the consolidation period in E antigen positive patient to less than 12 months, relapse is very high and only 26% remain in remission, whereas 75% relapse. 12 to 18 months, 40% remain in remission, 60% relapse. And more than 18 months, 71% remain in remission. Age is also important. Greater than 15 months of consolidation, very little recurrence. More than 40 years, less than 15 months of consolidation, very high recurrence of the virus after stopping treatment in E antigen positive patients. So what do we do in E antigen positive chronic hepatitis B? In those with advanced fibrosis cirrhosis, treat indefinitely unless a strong competing rationale for treatment discontinuation exists. Otherwise, at the time of seroconversion to anti-HBe, if less than 40, consider stopping after more than 12 months of consolidation. If more than 40, individualized decision to stop. Consolidation longer than 12 months, treating to surface antigen loss should be preferred, as I've already alluded to. So this must be remembered. And of course, after stopping NA therapy, you need very close follow-up. What about E antigen negative chronic hepatitis B? In cirrhosis, once again, lifelong, long-term treatment. No cirrhosis, treat indefinitely. For all practical purposes, treat indefinitely, unless a compelling rationale for treatment discontinuation exists. Why do I say that? Because if you stop therapy, these patients require follow-up every month for 6 months with very expensive tests. And unless your patient can do that, there is no point in stopping therapy in E antigen negative patients. Across guidelines, they now recommend, particularly EASL guideline, if no cirrhosis, E antigen negative disease, at least 3 years of viral suppression and capacity for close monitoring after stop, then you can stop therapy. So practically in E antigen negative patients, the treatment is lifelong. Results of treatment, HBV DNA suppression in about 20% with interferon and very high after 1 to 3 years of therapy with all oral drugs. Surface antigen loss, 4% at 1 year, probably 9% at the end of 5 years with interferon, whereas almost zero, even with 8 years of treatment with all oral drugs. So E antigen negative disease, surface antigen does not become negative with oral therapy. So you should remember that. And that's why the need for long-term therapy. Why are the guidelines recommending stopping therapy in non-cirrhotic E antigen negative patients? Because of this fact that they all develop flare, almost all develop flare, and 20% lose surface antigen. So they become sustained virological responders of the highest degree that you desire. Although 40% will require retreatment and the rest are in the middle, not requiring treatment, remaining stable, and not showing very high DNA levels. So that is the reason, because after flare, 20% develop surface antigen loss. That is the reason that the guidelines, particularly the EASL guideline, now recommends stopping therapy in non-cirrhotic E antigen negative chronic hepatitis B after 3 years of viral suppression if the patient agrees for regular follow-up. So these tests need to be done very, very frequently. So you have to remember that. If somebody using peg interferon in 2021 for treating chronic hepatitis B, which will be justified, he's not doing wrong, you must remember that early stopping rules can be applied at week 12 and week 24 based on surface antigen quantitative levels at week 12 and 24, and also DNA levels for E antigen negative chronic hepatitis B. I will not go into the details, but certainly you can consult these charts if you are treating a patient with interferon in 2021 who is B positive. So E antigen negative disease, what do we do? In those with advanced fibrosis and cirrhosis, treat indefinitely. Otherwise, treat until surface antigen loss. Antigen loss, unlike with nucleoside analogs, as I mentioned, so the treatment is practically lifelong. NA withdrawal strategies appear promising but premature to be recommended as a standard of care, as 20% achieve surface antigen loss and 60% remain off therapy despite stopping therapy. But you must remember that close monitoring is needed as flares can be severe. Next mistake, not considering pregnant women with HPV DNA of 200,000 for treatment in the third trimester, just for one reason, prevention of mother-to-child transmission. You can stop treatment after the pregnancy is over. The EASL guidelines recommend 12 weeks after the pregnancy is over, after delivery. And during these 12 weeks, the mother can breastfeed the baby despite taking tenofovir, which is the recommended treatment. Finally, I would just highlight this mistake that not checking HBsAg and anti-HBC prior to starting chemotherapy or immunosuppressive treatment. As I mentioned, some of these patients will develop activation of the disease, a very bad flare, and may go into decompensation and death. So always remember to do that. And this is where importance of anti-HBC IgG or total comes in, particularly if you are using strong immunosuppressants like rituximab, and you have to give preemptive oral nucleotide analog for during the therapy and at least 18 months after the therapy. The longer, the better. So this is all I wanted to talk about. I hope I finished in time. Thank you very much for your patient listening, and I wish you all luck in treating hepatitis B patients without mistakes. Thank you very much.
Thank you, sir.